Good afternoon and welcome to Best Start Resource Center webinar series. Today I would like to welcome you to the Healthy Eating and Weight Gain webinar with Dr. Zach Ferraro. Before we start, I would encourage you to please make sure that we know who is on the webinar by logging in the room with the following format: first name, last name, @organization, and number of participants if there's more than one. To change your login information to the attendees part of the screen, go to the top of the right box, top of your screen to the box that says Attendees. Click on the pod options to edit your information. If you are using your computer to listen to this webinar and are having trouble at all, please call in using the information sent to you, and it's also shown in the chat box below on the right-hand side. For any unresolved technical difficulties, please use that chat box to alert our support staff. The newly revised Healthy Eating and Weight Gain Key Messages PDF and the PDF of this presentation are also available in the Files pod on the right side of your screen. At this point in time, I'd like to welcome Dr. Ferraro to this webinar, and I'll provide you with a quick introduction. Prior to starting his MD, Dr. Ferraro obtained his PhD in maternal fetal physiology, held a CIHR postdoctoral fellowship from the Institute of Human Development, Child and Youth Health, and was a part-time professor in the School of Human Kinetics at the University of Ottawa. Currently, he works on a casual basis for the Division of Maternal Fetal Medicine at the Ottawa Hospital while also studying to become a doctor, and is actively involved with research looking at physical activity and nutrition during pregnancy and how prenatal interventions alter placenta nutrient transport and child outcomes later in life. He has published over 50 peer-reviewed articles and has given over 100 public presentations. He has presented at the annual Best Start Resource Center annual conference and at a number of our workshops across the province. For more information about all of that, you can visit his website at www.drferraro.ca. However, today his focus is going to be on a presentation that is going to directly link some of the information, the Prenatal Education Key Messages on healthy eating and weight gain. So just while I'm pulling up the presentation, I'd like to welcome everyone to this particular webinar, and I'm just going to pull up the first slide, and I'll hand it over to Dr. Ferraro. Welcome, everyone.
Great, thank you. Thank you very much for the introduction, and thank you again to Best Start for having me. I'm glad we all share a common interest in healthy eating and healthy weight gain in pregnancy, so thank you to everyone who joined in today. Just a note, before we begin, if you have any questions, let's try and field these as they happen. So please type them into the chat bar, and I'll try to field them as they come up. So these are my disclosures. I had funding from CIHR, both for research and personal, and then consulting and honorary from the groups on the bottom of the screen. The objectives of today's talk are for me to try and impart a complete narrative so you can work with your clients and your patients to provide them this story and take bits and pieces of this information and educate your patients and use some of the tools I'll discuss at the end of the presentation to help impart the key messages. Mainly what I want to aim to do is review weight bias and go over how prevalent weight bias is in the clinical encounter, both with doctors and patients and clients and allied healthcare providers. It's essentially ubiquitous everywhere we go. So I really want to show a way that we can understand our bias in an attempt to improve care with our clients and patients. Secondly, to no surprise in anyone in the audience, I'm sure you're well aware of the link between pregnancy weight gain and adverse child outcomes, but I will review very quickly some of the risks associated with gaining too much and gaining too little during pregnancy. And then, of course, on that note, what can we do to improve that? And I'll review some of the systematic reviews and some of the intervention trials to date that have shown how physical activity, healthy eating, and improving gestational weight gain are good for not only moms' postpartum weight retention, but for outcomes in the neonatal period and, of course, in the pediatric and early years. And then lastly, just reviewing some basic concepts of weight management, especially because there's so much going on in the media right now with so many celebrities gaining weight, Kim Kardashian, for example. And I really want to just put the focus on epidemiology and evidence-based medicine. So you can see on the right of your screen 3 circles with an intersection of the Venn diagram being evidence-based medicine. And what I really want to impart is that in this world there's just so much personal ideology surrounding eating and moving, and we really need to keep it in mind that epidemiology trumps ideology, and I hope to share that with you today. So here are the key messages that were mentioned, and they're comprehensively explained in the diagram, or in the document that you have at your disposal. And I just want to make one disclaimer, is that I don't have the very fine skill set that many dietitians have, so I'm not going to speak to specifics with respect to dietary prescription. That's outside of my scope of practice. But I will speak on a more global nature to hopefully, again, give you pieces of a story that you can create your own narrative with, whether it's in a group class or an individual counseling session with your client. So this story would be thoroughly incomplete without putting up this diagram, the spaghetti map of the UK Foresight program. And right in the middle of this diagram is energy balance. And intertwined are the many factors at play that contribute to positive or negative energy balance. Just so happens in our modern society, positive energy balance is much more common and much more prevalent. And you can see that food production, social influences on eating behaviors, one's individual psychology, whether they're an emotional eater, for example, their individual activity level, whether they're forced to be sedentary, their activity environment, the environment in which they live and grow and develop, and as well as one's own personal biology. And if you want to zoom in, I put the source there for those who are interested. You can see that it's very complex. There's many causal and contributing factors to positive energy balance. So it's simply not about eating less and moving more. And as I mentioned, it seems that everyone I encounter today has an opinion or something to offer with respect to eating and exercise. Humans who move and humans who eat seem to think that they're experts. And this is all over the internet with personal blogs and Twitter and anecdotes going everywhere. So I just want to make sure that we give credit where it's due, and that if you eat doesn't mean you're a nutrition expert or a registered dietitian. These are very specific skill sets that you can feel confident referring your clients to. Similarly, people who move and go to the gym and are engaged in recreational activities seem to think that they're competent and able to give advice. And just because somebody had a very inspiring story of change and positive response does not mean that that's going to hold true for everybody. So I really want to put that stories are great and they can be great motivating factors, but they can also do quite a bit of damage in the clinical encounter when people are starting to compare themselves to others. And we know very well now that each of us is different. We have a different genetic makeup, and our environmental influences, our epigenetic factors at play are very different. So this is why it's important to take advice from qualified professionals. On that note, across the board of healthcare providers, it's well documented now that weight bias and discrimination is real. And it's real because it impacts the care of the patient and the client. So first, I would like to start by encouraging everyone to use person-first language. In a very similar way that we do with patients with diabetes, they're not the diabetic patient or the cancerous patient or the demented patient. It's the patient with dementia or the patient with a neurocognitive decline. Similarly, it should be the patient with weight-related illness or the patient with obesity, the client with obesity. And this makes tremendous impact on first developing that initial relationship with the client. And research strongly supports this. So I encourage you after this or sometime in your spare time to test yourself, and you'll be very surprised with the outcomes. This is the Weight Implicit Association test, and it's put on by Harvard, and the link's provided for you there. And what it does is it gives you, in about 10 minutes, you can complete this test, and it gives you a good idea of where you stand with respect to your weight bias. And I'll tell you, I've been in this area now for over 10 years, and I was surprised at my results. So I encourage you to take a peek, because the first step of addressing bias is being aware of our own. And this falls very fluidly into weight maintenance. So weight loss in the postpartum period or weight management during pregnancy, it's important to acknowledge to our clients that it's an uphill battle. There are so many contributing factors, as you saw in the spaghetti diagram, that encourage positive energy balance. My bet is that most of us are sitting down right now listening to this podcast, and that we're not standing up, which contributes very little, but some, to negative energy balance. And that in our food environment we've created, very few people have the opportunity to cook from scratch and have whole foods. So you'll see that it's very much about a time management planning issue, and why unhealthy dietary choices are so easy to engage with. And this just speaks to how times have changed. And I put these graphics here for you to either show the slide to your client, but things are different now. So when you use anecdotal studies or anecdotal sayings of, oh, back in the day, or my mother or my grandmother, well, this is all fine, but the epidemiology of the times have changed. We are forced into sedentary behavior. We are forced to consume highly palatable foods, and we really are competing against the tide of calories that work against us. And so on the left-hand side of your screen, for those who aren't aware, the guy in the middle is the second largest baby born to date, and that's a large for gestational age neonate. And to the left and right are small babies. And this is important because now there's a, I'll speak a lot about large for gestational age just because the magnitude, the proportion of pregnancy where large babies are born is more common now, although small babies does pose a risk, and I'm not going to speak to that in the presentation. They do have their independent risks for weight-related illness later in life, but they are through different mechanisms. And so I hope to share that with you today. So this slide didn't show up last time, and it doesn't look like it's showing up today, but it reviewed very quickly in the first, second, and third trimester of what the risks of excess weight were in early pregnancy. And it's become such a common topic in popular culture that it's even been put forward in Time magazine, how the first 9 months can shape the rest of your life. Research is now suggesting that the preconception period or the intrapartum period may be most beneficial to intervene given some of the results of the intervention trial. So this is just very important, not to instill fear or monger your clients, but to just share that this is a teachable moment, one where positive changes, even the smallest change, can have a very beneficial effect, not on only the health of the mom, but also on the health of the baby and the future generations. And I know most people don't want to hear about epigenetics, but I really think it's important to discuss how your genes are nature loading the gun and how environment is pulling, the environment is pulling the trigger. So meaning that we're all born with our DNA complement, and this can't change. But what can change is how our environment interacts. So even if you have parents that were large or parents who had diabetes or cardiovascular disease, this is not a doom and gloom scenario because epigenetics is reversible, it's malleable, and it's highly plastic. And these can change with beneficial to benefit the patient and client through healthy eating behaviors and through physical activity. So epigenetics is simply how the environment interacts with our genes. And even if you are a high-risk person, you can still play out that hand to the best of your ability, to the best of your favor, and still come out with positive and optimal adaptations. So it's not an issue of willpower or personal choice, largely. It's the environment we live, and it's the genes and epigenome surrounding our genes that contribute to our disease risk. So this I found helps in a very simple way, take the blame off the patient. And it's not giving them a free rein or free license to consume or anything of this nature, but it just shows that there are larger, more complex factors at play that go beyond willpower and personal choice. And this is what we do. We empower. And on one of David Barker of the Barker hypothesis, the physician and scientist who came up with the developmental origins of adult health and disease, and one of his final letters he penned in Nature Communications, he urged us to change the public health environment for the health of mom and baby, because truly it transcends individual clinical encounters, and there need to be larger factors at play to change the foodscape and activity environment in which we live. So back to my previous point about pregnancy weight gain. It's everywhere. And you can see in this slide that there are some negative terms used when describing weight gain. So the point of putting this up is that your clients may come to you because they follow these people on Instagram or Facebook or whatever have you, and that there's this fear instilled with pregnancy weight gain so much that it's deterring people from wanting to gain weight in pregnancy. But it's important to acknowledge that pregnancy is one of the times where weight gain is normal. It's acceptable to gain weight. You're supposed to gain weight. It's just about the amount of weight you gain. So it's creating a healthy narrative around pregnancy weight gain and following the best evidence and best practices, and not to instill fear or quote-unquote freak out. And this is everywhere, bad advice. I pulled this just recently before the first webinar. And And you can see that the tips they gave on the bottom, and I'm not even going to go into it because I want to keep my friends here, but cleanse, for example, cleanse. Unless you have dysfunctional kidneys or liver, there's no need for a cleanse. And if you restrict water, macronutrients, food, for example, it puts your body into a state of starvation, essentially, where your body wants to hold on to the nutrients like a sponge. So by restricting and going on these fad diets and these cleanses, you can tell your clients that it's actually counterproductive to flushing the body and nourishing it properly. And I just put this here as proof that it's been published in the Huffington Post, a very widely read news media, that it's prolific. So I'll change gears a little bit and talk about what I call the Goldilocks effect of pregnancy weight gain. Many of you are aware of the story, but the same holds true for weight gain. And I hope to show how gaining too little and too much can contribute to risk for mom and baby. So I'll first start with a study that we did now more than a few years ago, where we looked at the independent effect of gestational weight gain in excess of the Health Canada guidelines and how that contributed to the birth of big babies. So in a group of 4,300 mother-infant pairs from the Ottawa and Kingston birth cohort, we looked at body mass index category, because that's how Health Canada defines the weight gain recommendations. So on the x-axis, or the bottom of your screen, we have your BMI category, and on the y-axis, we have percentage of women who fall into each category. Red is women who exceeded the guidelines, and green is women who met the guidelines for their specific body mass index pre-pregnancy. And what you see in this graph is that there is a disproportional larger number of women who exceed the recommendations for gestational weight gain in the overweight and obese category. Now, this is largely because these guidelines for women with excess weight pre-pregnancy are more narrow, as I'll show you on the next slide. But it's important to note that they are in excess and that this does pose a risk. But encouragingly, it is a modifiable factor. And just to note, it is the women who meet the guidelines. Normal weight women tend to gain more weight, absolutely, but relatively it's the women with obesity and overweight that exceed the guidelines through that narrow window of gain. So I'll ask this question, and I like to put this out. Who's at greater risk of having a big baby if gestational weight gain is an independent predictor of large for gestational age neonates? On the left-hand side of your screen, you have a woman who started pregnancy at BMI 33. And at 39 weeks, she gained 8 kilograms. And another woman on the right-hand side of your screen who started pregnancy at 20 kilograms meter squared, so normal weight according to BMI category, and gained 17 kilograms by term. Well, interestingly enough, they're at the exact same weight. And these two slides here are simply to articulate the point that gestational weight gain is the modifiable, independent risk factor for a big baby. And you can see that if you start pregnancy heavier, but you gain acceptable weight by term, you can protect from some of that additive risk of the gestational weight gain. That independent effect of gestational weight gain becomes a little bit less in that equation of risk. Versus a woman who may feel that she's doing a great job in starting pregnancy in a normal weight, which is great and should be commended, but for some reason or another, gains in much more than is recommended by Health Canada, she is now at the exact same risk. So this just shows that the environment does change, and you can modify things at your disposal through the healthy behaviors we'll discuss. So for those who are unaware, which I'm sure no one on this line is unaware of these now, but we still find in some of our research that some of the clinicians we speak to and some of the allied care providers are actually not aware of the Health Canada guidelines. This is the IOM Guidelines taken from the 2009 document, and Health Canada has the exact same guidelines. So you're using to see, if you start pregnancy a little bit heavier, your window of gain is more narrow. If you start pregnancy lighter, you have a wider range of gain, and this is just simply because there's natural factors, for example, maternal insulin resistance, and adequate substrate if you start pregnancy heavier to sustain life and development of the baby in a very healthy and fruitful way. So to put this into a graphic picture, these are the birth weight for gestational age charts for Health Canada, and I've just outlined what a normal or average for gestational weight baby is. And keep in mind that this is just, these are just more population level evaluation tools, and the chart on the left for the individual clinical encounter, and that there will be women who give birth to babies that are large, that are just simply constitutionally large, and that they don't have any extra undue risk. And that's beyond the scope of the talk today, but it's just to acknowledge that not every single baby who's born large or small is at increased risk. It depends on the other factors in play with that personal pregnancy. Some people are constitutionally small, some are constitutionally large. And this is just how nature has designed this. So when I look at the data, I think this picture really describes it nicely, because sometimes we're asked, what's the largest contributor to big babies? Is it gestational diabetes? Is it overweight and obesity? Or is it excessive weight gain? When 2014, Kim answered this question, published in the Green Journal of Obstetrics and Gynecology, controlling for many competing factors. So what you see along the x-axis is different ethnicities, and along the y-axis is the population attributable fraction in percent. And what this graph shows is that excessive weight gain is the predominant factor contributing to large babies. You can see that gestational diabetes in red plays a role, but it's not nearly as significant as the effect of gaining in excess of the guidelines. And so this is encouraging, because gestational diabetes at times is largely uncontrollable. Overweight and obesity, once you start pregnancy at that weight, the opportunity for prevention is lost. So now we're on to secondary prevention or gestational weight gain management, which is great, because this factor in the middle, the blue factor, weight gain, is the modifiable factor that we can change through healthy eating behaviors and physical activity. And so not again to scare the clients, but to articulate to you in the audience now that there is a tremendous amount of data to show that on the left-hand side, a meta-analysis of randomized controlled trials to date looking at excessive weight gain and risk of child obesity, that in fact there is anywhere between a 20 and 60% increased risk of having a child with obesity if you exceed the guidelines. On the right-hand side of your screen, the effect of birth weight. Having a large baby increases the chance greater than twofold of having a child with obesity later in life. And so this is now becoming less and less of a hypothesis and more conclusive, given the replication of several meta-analyses demonstrating the same effects. So what about gaining too little? And I used to have a slide about gaining too little about infant mortality, but I thought this was very interesting because it just came out 2 weeks ago in JAMA Psychiatry, looking at the effect of inadequate weight gain in pregnancy and non-effective psychosis or schizophrenia, for example, in the offspring. And what this showed is that when weight gain was insufficient, it increased the risk of schizophrenia in the offspring later in life. And so this was a very large study done in the Netherlands. But the key message for this is that with all the popular culture and media going on about restriction and harm and fear of weight gain, is that we really want to channel the message to be healthy weight gain, that it's natural, that it's acceptable, and that there are risks of gaining too little in pregnancy. And this is shown right here in this slide, where in the middle of the graph, where women meet the IOM recommendations, and this is in a group, as you can see at the top of that graph, BMI less than 25. The value of evaluating this in women with BMI less than 25 is that it eliminates or slightly attenuates the effect of shared obesity-related genes in those moms. So this is moms who do not have obesity, who meet the guidelines, to really demonstrate that even in these women, if you gain too little, you have a roughly 60% chance. If you gain too much, a roughly 80% chance of having a child with overweight and obesity. So again, more proof of concept demonstrated in large epidemiological studies that healthy weight gain is very important for downstream child health. Now, if I look at the timing of gestational weight gain, some people will ask, well, we have clients who come to us, and by the time we see them, they're already outside of Health Canada's recommendations. Well, this is problematic, but there's also hope. For example, in the study by Margie Davenport and Michelle Matola from Western, they looked at the effect of early exceeders. And what they did was they divided pregnancy in two. And they looked at those who gained too much early in pregnancy and then recovered, and then gained too much in the second half of pregnancy and then recovered. And they have the groups shown on the right. I won't get into the nuance of the study, but suffice it to say, the take-home message was that timing and rate of gestational weight gain did alter fetal growth, and that when they gained excessively, and I'll just clear that out for a second, when they gained excessively early in pregnancy, as shown by the blue bar on the right-hand side, it was similar in risk to women who gained excessively overall. So that early excessive weight gain seems to be a factor. And I didn't change the slide set because we want to give the same webinar, but just published this week in Obesity was a study from Harvard University, Emily Oken's group, who's done tremendous work with Project Viva to again show that early pregnancy weight gain in the first and second trimester in excess of the guidelines contributes to alterations of hormones that promote growth, but also alterations in anthropometry in children at term. So that does sound dire, but what's very encouraging is this. A group from Germany has shown that if you do gain most of your, in excess of the gestational weight gain guidelines by the third trimester, or early in pregnancy, sorry, in the first and second trimester, and then you grow into that pregnancy weight gain and stabilize your weight gain in the third trimester, that you do lower your risk of child obesity. So to recap, early weight gain does have an effect, but you can offer the message of hope in the third trimester if you're counseling your clients then, is that we can still, there's still time. There's still time to modify the risk. And this is shown here that there is roughly around a 27% decreased risk if they recover in the third trimester. So you can recover. And when we look deeper into the factors at play as to why women are gaining in excess, we really do see a patient-provider discrepancy. And while we're not here to assign blame on the patients, for sure, or on the providers who have a tremendous amount of work to do in a very short visit, checklist on checklist to go through in prenatal care, is that there are key factors that come up. One is that there's very little counseling on healthy eating, very little counseling on physical activity. The number one nutrition recommendation surrounds multivitamin. Number two largely involves foods which you don't want to eat, which is very important, but I like to keep things positive, and maybe we should focus on foods that are acceptable to eat, or ways in which we can promote healthy visions around food, so we can foster the development of food and creating a natural food environment. That really, those are the main factors at play. Another one we hear are many myths surrounding weight gain. So 4 points I think that are very important for prenatal care providers to do, and I would encourage even all healthcare providers to do, is number one, dispel the myth. Dispel the myth that weight gain is harmful. Dispel the myth that all is lost if you gain in excess, which is not true, as I showed you. You can reverse the risk. The body is malleable, it's plastic, and if you gain, it's not the end. What we try to do is prevent the rate of gain, and we try to do that by harnessing in on the modifiable factors and managing medical comorbidities. Distill the evidence. Create stories around weight gain. For example, the Goldilocks effects of healthy pregnancy weight gain, I found, has met some with smiles. Minimizing the bias, disseminating the truth, and then individually working with your clients and finding out ways which can work for them. And I will talk about that at the end when I discuss the 5 A's of healthy pregnancy weight gain. So when creating a narrative and describing healthy weight gain and distilling the evidence, it's important to understand, for the client to understand, what are the components of weight gain. And putting up a quick graphic like this may be helpful, Because what it does show is it shows that there are different factors at play as to why they're gaining weight. And these are natural factors of pregnancy. It's well known that you accumulate fluid and that there's edema associated with pregnancy. However, it's also important to know that where there's room for excess gain is not really so much in the amount of fluid or the size of the uterus per se, but it's the fat storage is where people tend to gain in excess. Sure, the babies are heavier, but in magnitude of grams. But if you're gaining in excess by kilograms, that's where we have to target our interventions. And so I only put that there to understand that the fetus is very small, less than the size of your fist in early pregnancy. And so dispel the myth that you need to eat for two. If you needed to eat for two, that would make sense if the baby was 5'4", 125, 130 pounds. But in fact, it's a very, very small. So there's modest energy requirements that are needed, so much so that some pregnancies don't require any excess nutrients because of the natural insulin resistance of pregnancy that preferentially shuttles glucose and fatty acids and protein through the placenta. And we've shown that there's ways to change this through physical activity such that you can have a healthy complement of transporters and you can reorganize the placenta to make it more efficient through walking and physical activity. So number one myth is that you do not need to eat for two. You need to eat twice as healthy, as you've probably heard over and over again. Pregnancy is not a license to consume, as some may have heard from the past. Their great-grandmother, their grandmother, Manja have an Italian background where consumption was very, very common back then. Well, the times have changed, as I said. And what about physical activity? We hear sometimes that physical activity will cook your baby. And I can't say that it will be ridiculous. Everyone has their own thoughts, but there's some things at play. And what we've done in this paper with the late Andre Gruson and my old supervisor, Christy Adamo, is thoroughly document the value of physical activity in pregnancy. And more research is coming out every single week about the value of physical activity. And I want to say physical activity because it's not CrossFit, because it's not necessarily exercise. It's simple human movement. The number one reported modality of physical activity in pregnancy is walking. Walking has tremendous effects on acute insulin sensitivity and regulation, such that if you encourage walking before a meal, it helps clear sugars and fats more efficiently than if you just remain sedentary in both those times. If women are active before pregnancy, we want to encourage them to be active during pregnancy, to follow their body, but to be well aware that there's really no intensity at which they're going to work at volitionally before there's risk to the baby. So the CSEP has guidelines, checklists to screen the PARQ or the PARMEDX for pregnancy, to screen for risks, contraindications to participation. But most women don't have those risks, so walking especially should be encouraged. And in 2017, there's been some tremendous evidence to come out in Nature to show that not only are there the added value of heart fitness and respiratory fitness and everything we know why exercise is good, mental clarity, but there's things at play now such as preventing cancer, reversing age-related change and eye degeneration, improving your memory. So we used to have associations for these factors, but now we're starting to understand the mechanisms at play as to the true benefit of exercise or physical activity. And so I know this is a non-pregnant individual, but I've written on the topic and researched it before. The body responds to physical activity in pregnancy in much the same way it does when you're not pregnant. Other than a few nuances, which I'll provide a link to at the end, you can encourage physical activity because the response is virtually identical. So something you can say to your client is, some is better than none, but more is better than some. Do what you can, do what feels right. And I put this graph, another meta-analysis, just to hammer home the point that the number one predictor of death and heart disease in both men and women is physical inactivity. And what this graph shows is that for every one metabolic equivalent that you increase your physical activity, when one metabolic equivalent is akin to walking on the sidewalk at a very slow pace, at 3.5 mils per kilogram. It's just slightly more than resting. And so one net increase in physical activity is significantly protected against heart disease and death. So you don't have to do much, but the more you do, generally the better it is. But listen to your body and speak to your healthcare provider. I take this next slide from the Diabetes Prevention Program because what they did, and this was look at the incidence of diabetes over 4 years comparing lifestyle with metformin. And I know metformin is now being used in pregnancy to manage impaired glycemia, but what is very important to articulate to your clients is the beneficial effects of the lifestyle management. Through healthy eating, dietary support, and physical activity, at 4 years there was a lower risk of diabetes with the lifestyle than there was with the drug. So I know people in pregnancy are very cautious about what goes into their body. This is more proof that you can support the added benefit of diabetes risk reduction with lifestyle management. Not only do you get a reduced risk of the actual disease, which you see again on the x-axis in time, in months, and y in weight change, the same principles apply in postpartum, is that not only does exercise help minimize diabetes risk, but in this study, it also helps sustain weight loss, whereas the drug did not do anything of that nature. So if you truly want to help manage your weight, and I articulate not lose weight, but manage your weight, incorporating physical activity into the regimen is important. Furthermore, if you look at exercise, again, years from randomization on the x-axis, and the number of METs, or the amount of physical activity one participated in per week in the diabetes prevention study, you can see that the drug and the placebo group didn't do any extra activity. So they weren't reaping the tremendous benefits of physical activity. And as I showed you 3 slides earlier, the cardiorespiratory fitness, or the VO2 max, is the #1 predictor of death and heart disease. So simply by moving, you're minimizing your risk. So I'm asked, okay, you said exercise is about managing weight, not losing weight. And I really want to articulate with the next 2 slides that exercise is not so much a weight loss tool in the postpartum, but it facilitates proper energy consumption. And I'd like to ask these 2 questions. It's not so much about energy out, because you don't really burn that much energy when you engage in physical activity, but you tend to choose healthier food options. Now let me ask you, if you were sleep deprived and doing an all-night call shift, or up with your child all night and you're feeling very stressed out and tired, are you more likely to choose the pizza, the burgers, the junk food of your choice, or the healthy chicken salad option with low-fat vinaigrette dressing? Well, most people answer that they're going to choose the highly palatable, satiating option of the junk food. And if you're more well-rested, you're more likely to engage in physical activity, you're more likely to choose the healthy food option. So really, exercise is about honing in on the energy gap. The energy gap is, for example, people who are physically active are better able to match their energy expenditure with their energy intake. So if I took 2 people, one who exercised regularly, and asked them to consume this buffet ad libitum, or as much as they'd like, I would see that the person who exercised was able to better match their caloric intake with that which they expended to meet their basal metabolic rate and ensure positive energy balance. Whereas the person who did not engage in physical activity, you could say that they're less optimized. Their body is less aware of the currency of life, which is calories, and they overshoot their intake, and the gap is greater, and therefore they get into positive energy balance. So exercise really is more about energy intake opposed to energy expenditure. And I'll show that here. In the middle you have your basal metabolic rate. And if you burn 1 calorie per minute per day, and there's roughly 1,440 minutes per day, you're at about 1,500 kcals per day just sitting there, just sitting in a bed, lying there. That's what your body requires to live. And so if you add a little bit of physical activity on top, you can see here that it's a very insignificant amount of energy expenditure, that the most energy expended in the body has to do with the body itself, the fuel that the body requires to simply live and keep the heart and the brain and the nervous system functioning. So if we're trying to understand energy balance, it's very important to articulate this point to your clients, is that exercise and engage in physical activity for the health benefits, the fact that it helps you sleep better. If you sleep better, you're more likely to engage in physical activity and not feel tired. If you sleep better, you're more likely to have mental clarity. You're more likely to feel like you want to prepare some food from scratch and not engage in a quick fast food restaurant stop because you're tired and cranky. And if you sleep better, it's well documented that it improves several other factors with your metabolism. So you can see here that the main mediator might be involved with sleep. And I'll offer up a couple of side points, because at this point last week in the presentation, someone asked, so what can you do about sleep? Well, there's a couple things that you can do. It's really about fostering healthy sleep hygiene. And by sleep hygiene, I mean creating an environment around sleep that encourages you to fall asleep quickly, stay asleep, and get the best sleep quality possible. So you can, one, minimize screens in the bedroom. Put those phones away. We're all guilty. And I have to make a conscious effort myself to keep the phone at least 2 arm's lengths away at nighttime, or else I find myself reading from the phone. But 1 hour before bed, put the phone away. Turn the lights down in the room. Create a cooler environment, a darker environment. And these are just some strategies that some people have used. Minimizing caffeinated beverages after 2 o'clock. Engaging in physical activity also helps with sleep. So just some quick things to do to encourage sleep, because sleep seems to be the nexus here about consumption and consumption helping physical activity. It's this tight intertwined web that all relies on all the links contributing in full capacity. Another thing you can tell your clients is that the scale, if they want to measure themselves, that's fine. You can't tell them what to do per se, but we're going to leave the measuring to the healthcare providers, because the scale is simply a metric for us. I know I'm talking today about weight and pregnancy weight gain, but I'm also talking to an educated group of prenatal care providers, and we're using weight here simply as a marker. The scale has very little clinical utility other than, in medicine, nursing, the unexplained weight loss or weight gain. If you have no reason why you're losing weight, then that's a problem. So you should see your doctor. Or if you're gaining weight, maybe you have a metabolic disorder of some kind. Checking thyroid, for example, might be top of the list. But for the day-to-day individual to be stepping on the scale, it can truly distort their view of all the great work they're doing if they're engaging in physical activity. Everyone knows that, well, maybe not, but everyone on this line knows that muscle weighs more than fat, and that you change your body composition before you change your weight status when you engage in physical activity. So if you're not seeing numbers on the scale change, there's this perception that it's not working. But when in fact, the second you move your body at the cellular level, things change. And it's only a matter of time before your physiology follows. And back to the point about weight bias and discrimination, I'll ask this question. Who's more active, normal weight individuals or those with obesity? And in an article I worked on with the authors here, we tackle several misconceptions about obesity. And I just want to put, if I ask this question to a bunch of undergrads, they would say, oh, the normal weight person's more active. And that's just not to their fault. It's just because of the implicit bias that we have in our world. In fact, if you look at the Canadian Health Measures data, which is directly measured physical activity in a nationally represented sample of Canadians, it shows that people with obesity and those of normal weight actually engage in the exact same amount of physical activity. It's roughly 7 to 10 minutes of moderate to vigorous physical activity per week. Well, you know what that is. That's just a Canadian inactivity crisis. And if we went so much to say that the individual who weighs more has to generate more force and use more energy to get them through that amount of physical activity, you could say, in fact, that the individual with obesity is burning more calories. So when you have to look at the science, and you have to understand it, you put these biases aside. So I just put that there because I thought that's a very interesting point, because I always get that, oh, well, normal weight must be much more active. No, no, no. We have an inactivity crisis in Canada. It's not just about obesity. Similarly, I'm always asked, well, a calorie is a calorie. Chemistry is chemistry. Well, okay, I get it. I get it. On the next slide, I'll talk about how chemistry and physics and physiology are different. But what we show here is that on the left-hand side, sure, you can eat a lot more of the junk, but the left-hand side weighs a lot more, and you're going to really stack the deck against you if you want to go for the junk food versus the healthy food. You know, you can ask what weighs more, 100 grams of this or 100 grams of that, and they're going to say, oh, the junk food. Well, they're both 100 grams. So that's kind of a trick question. The thing is that you're going to see a lot more of the healthy food option on the plate per unit energy. So we want to encourage the healthy food options. We don't want to encourage them to restrict the junk. We want to encourage them to minimize the junk and eat as little as they can to feel good. So let me now talk about why people cheat on their diets, or why people fall off the bandwagon. And just for the record, the next couple slides are non-pregnant people. But what I want is just to articulate the point that there are competing factors. There's physiology and hormones at play that predict weight regain. And in a very seminal study by Joe Perito's group, they showed that there are hormones in your body that persist after weight loss. So I'm going to talk about ghrelin. Ghrelin being the hunger hormone that spikes right before your meal. And what they did, let me orient you. At time point 0 is the beginning of a weight loss intervention. At time point 10 on the x-axis, week 10, that is when the intervention stopped. From 10 to 62, they just tracked the patients. There is no intervention. On the y-axis is the weight in kilograms. So you can see at time point 0, at the start of the intervention, the patients are heavier. At the end of the intervention at week 10, the patients do lose roughly 10 to 12 kilograms. Great. But what you see over time when the intervention stops is that the weight comes back. Much the same that would happen in pregnancy. If you manage your weight in pregnancy and you stop the intervention in the postpartum weight retention now may become an independent risk factor that puts you up in a BMI category for the next pregnancy. So the point of this is that when the intervention stops, the weight comes back. Now, why does that happen? Well, is it a lack of willpower? Absolutely not. What happens is hunger hormones increase. So let me just orient you to this graph before you get concerned by the messy nature of the 3 lines. Along the x-axis is postprandial time. So at time point 0, the patients ate a meal. And they watched and took blood samples serially until 240 minutes. Y-axis is the concentration of ghrelin, the hunger hormone. So as they expected, the hunger hormone would be high before a meal. And if you follow the black line, as they ate the food and stopped eating, as time went on after the meal, the hunger hormone went down. But as time progressed and their body digested the food, they got hungry again and the hunger hormone went up. And that's how we eat. Simple as that. Oversimplified, but that's how we eat. If you look at the blue line, that's 10 weeks after the intervention. So now, 10 weeks after the intervention, at time point 0, their ghrelin hormone is higher. And that's the take-home point. The hunger hormone is higher because they lost weight. The body is defending against that lost weight and encouraging weight regain. And it's not because of lack of willpower, like people regain weight, it's because of hormones. So this is just one such example of how the hormones persist. And you can see that the blue line is always higher than the black line. So the hunger hormone persisted at 10 weeks, and again, 1 year after the intervention, it's still higher. So the body has still not readjusted to that lost weight despite the weight being regained. And that's the point, is that your hunger hormones spike, your muscles become more efficient. They use less energy when you lose weight. You want to move less, you want to eat more, and thus you regain weight. So these are these factors at play. So what's driving you to eat? Well, it's the brain and the brain's connection with the GI. And you can just see here, these are just simply to show that using a visual analog scale, that the patient's hunger was higher after the intervention, and even when the intervention stopped, in line with the ghrelin, their self-perceived hunger was higher. Their desire to eat was higher, and this is why they regain weight. So more evidence to show that small changes need to happen so you don't trick your body in the postpartum period. Our bodies are designed to store. If we didn't store that energy, we would flatline. That's why we're here today to talk about the story. In fact, we have genes that were designed for opportunities of famine and very little. We are just subjected to an environment of plenty, which is counterproductive to how we're designed. So I hope that just creates some talking points for you to tell your patients so they can feel that it's not their fault, so they can understand that there's very little caloric expenditure with physical activity. That physical activity is about the health benefits, helping you sleep better, helping you choose healthier food options, and that there's factors at play that are beyond willpower that promote weight gain in the postpartum period. So what can we do? Well, we first have to understand that, yes, a calorie is a calorie when we're talking about physics and chemistry, and that things balance very nicely on paper when you're doing math or in the lab when you're balancing beakers. When you look at biology, which is our living systems, they're variable, but they're mostly predictable. But humans are very interesting creatures. Our physiology, as Dr. Arya Sharma says, is biology messing with physics. And I completely agree. And this is exactly why weight regain is so prolific and excess weight in pregnancy is common, because there's factors in our design that promote weight gain to protect against this quote-unquote famine, which today never comes. So for those who are interested in a little bit more in-depth training on the 5 A's, I don't have time to train on the module today, but we're going to look at some of the key points of the 5 A's. So Adam King and his group at BC Perinatal Services, we designed this module to take allied care providers and care providers through, and I have the objectives here. There's no cost, and there are credits available for continuing education. It gives vignettes and discussion and some pre-post quizzes for those who want to be a little bit more well-versed in the 5 A's. So here, just for viewing, I won't go over them. Simple factors linked to weight regain. In an article which I do link to at the back that kind of talks about how we have this distorted view of body image and how calories have become the focal point when in fact it should be more about the behaviors. How do you maintain lost weight? I'm going to get into some factors here that work for pregnant and non-pregnant individuals. So what can you do? These are taken from the IOM report, but several groups now have reproduced these to their own institutional standards, and they hand them to the patients or to the clients. And they show that when you write something down and hand it to the patient, the intervention is more likely to follow through on beyond simple verbal advice. So by identifying a healthy physical activity prescription or a gestational weight gain target, it allows the patient to be aware of their goal. It's important for goal setting to understand where you are and where you need to go. Not to be the focal point, but just to kind of help gauge where they're at. So lifestyle prescriptions are real and they're showing to be of benefit. Self-monitoring is another key factor. Self-monitoring is one of those things that keeps behavior change together. And that's a line from Dr. Friedhoff, and let's give credit where it's due. Self-monitoring has been well documented in the literature, in the National Weight Control Registry, in many of the prenatal interventions, in the non-pregnant population. And whether you use the good old paper and pencil, your smartphone, your Fitbit, whatever it might be, self-monitoring is there to help you not choose good and bad days, but to help identify where there's been gaps. Because when you identify the gaps and you approach it that you're not judging the good versus bad day, you can say, I wonder why I got 2,000 steps today. And then work around strategies to help improve that moving forward, not so you feel bad. So self-monitoring is about identifying gaps, keeping the behavior constant, writing your behaviors down, because research has shown again and again, when you write things down, when it becomes habitual, you're more likely to stick to the routine, and you won't slowly creep off the program. We all think we're doing a great job, but if we don't write it down, we tend to go to the path of least resistance, which is sedentary nature, and then back to the poor dietary choices. MyFitnessPal is another app that can be used. It's free, lots of culturally relevant food options. They provide graphs. It's simple to use, and the most basic platform is accessible for everyone. And given the ubiquitous nature of cell phones today, considering there's more cell phones in Africa than there is running water and flushing toilets, and that's an actual stat, that this is not necessarily a bad option for your clientele. It allows them to input their food. It allows them to identify, again, not good and bad days, but maybe why they had 3,000 calories more than they were supposed to on Thursday. Oh, they were driving from place to place and they had to get fast food. So what it can help identify is opportunities for intervention. Writing things down can say, oh, maybe Thursday is going to be a busy day. Maybe Wednesday night I prepare a little bit of extra dinner. I package it in my Tupperware. I take it with me so I don't have to go to McDonald's. Just simple things like that. This is from Sarah McDonald's group at McMaster, where she shows that even improving gestational weight gain awareness has added benefits. So again, keeping it for the care providers, but you can encourage them to take these sheets to their physicians. Some proof showing that simple lifestyle intervention in primary care has benefit is taken from the Mighty Mom study. A group of midwives ran this study, and they show that when in fact they do intervene and they do modify the behaviors or monitor the behaviors, that they do limit the amount of gestational weight gain. The biggest trial to date by Jodie Dodd's group in Australia was a very large representative trial on the west coast, along the east coast at all major centers in Australia. And what they showed was that with physical activity and nutrition, that they did decrease the risk of macrosomia. And when they did a subsequent analysis looking at the cost effectiveness, that it was immediately cost effective, or cost neutral, sorry. So they broke even, which was great. And I'd even argue that in the long term, given the tremendous effects of fetal programming developmental origins, that there would be a future cost saving. And so the question was posed, would a mobile intervention be better? Well, unfortunately, we don't have any information to date on pregnancy mobile device interventions, but there is tremendous amount of data on smartphone technology in non-pregnant patients. And what they're showing again and again is that they're not alone. Just having a smartphone or just having a Fitbit is not enough, but using it as a self-monitoring tool and being cognizant of your behavior, using that to identify times for intervention, are facilitators of behavior change. So more proof of concept that self-monitoring is beneficial. Everyone who has an iPhone has a pedometer, and that's built into the health app there. And so it's just simply making clients aware of that tool maybe can help them get a few extra steps per day. Mobile interventions, as mentioned, are not currently available in pregnancy, but there are some available in non-pregnant patients, and they have been shown to be beneficial and produce clinical meaningful weight loss in non-pregnant groups. Currently, there's 2 under review in pregnant populations that is not available right now. But when we look at the e-health and weight management in pregnancy and postpartum, for the very few studies, there does appear to be a favorable effect. And this paper is currently under review from Christy Adamo's group. So this piece I just put off because it was published last week, and it looked at the association of prenatal care with gestational weight gain compared to individual prenatal care. And I don't want to put this here to discourage, but it just, what they showed in this large study published in the Green Journal was that there was excess weight gained in the group care versus the individual care. And I just put this here not to judge or point fingers, but I just want to bring up the point. Maybe in your conversations with your groups, you just articulate that if anyone has any individual concerns, to come and speak to you after the class if time permits, or to ask them to bring those individual concerns to their healthcare provider. Because in the long laundry list of checklists we have to go through in the clinic, unless the patient's proactive and volunteering some of their concerns, sometimes they do go unaddressed. So it's important to just acknowledge that there was some differences, and because the one-on-one care addressed some of the barriers more efficiently. So we do know what works. We know that creating a healthy environment around food, being aware of calories, a caloric literacy is important, not obsessing over calories. That engaging in physical activity is very important. And independent of physical activity, getting up and moving those legs, filling your water bottle extra so you don't sit all day at work. So you force yourself to go to the washroom. You set a timer with your phone. You go for a walk at lunchtime. You create a mall group and you go on Sunday morning to the mall if you're in a climate where it's too cold, or during the winter in Canada. Just simple strategies like this to encourage these behaviors, because they do truly make a difference independent of weight. And as we wrap up, getting in more towards the 5 A's here, when it comes to any lifestyle intervention or any intervention for chronic disease, as soon as you remove the intervention, the problem will come back. If you're taking blood pressure medication and you stop taking it, you're hypertensive again. If you're taking, you're using physical activity and nutrition to control your weight and be weight stable, if you stop that, the weight is going to go up. If you're struggling with overweight or obesity or excessive weight gain in pregnancy, don't expect that imposing an intervention will help you lose weight. That's malaligned thinking. It should be more about that it'll stop the weight gain or help you create healthy weight gain for pregnancy. So that's important. So in the postpartum, it's important to acknowledge that by engaging in these behaviors, you're not going to lose weight. You'll just attenuate the rate of weight gain. Right? So when you take the blood pressure pill, for example, you're not going to become hypotensive. You become normal blood pressure, right? So that's what these interventions do. They don't put you into the negative, they make you more optimal. So in Ottawa, and I know several groups right now are testing this, especially in Alberta, larger trials are going on, evaluating the effects of the 5 A's. So I'm going to skim through a couple of the key principles, but I encourage you to take a peek at them. So the 5 A's simply are asking for permission to discuss weight, assessing the causes of discordant gain, so whether they're gaining too much or too little, advising on the risk, but then also on the management options, agreeing on a plan, and assisting them with follow-up. So the principles are, and I won't read these in their entirety, but one, because weight gain is expected and normal for every pregnant woman, a discussion about gestational weight gain should occur with them all. And whether or not that's their physician, if that's been done, or briefly mentioning the topic during your prenatal sessions, it must be done. It must be on the radar because of the tremendous benefits about healthy pregnancy weight gain. 2, healthy weight gain is not about weight. It's really about the behaviors that facilitate the weight. It's about the health of the mom and baby. So we should be focusing on those behaviors and acknowledging the small wins independent of whether weight is gaining too much or too little. We use the weight as a clinical indicator, but we can praise the behaviors or intervene on the behaviors. Removing roadblocks and addressing the concerns, the causes, this is much easier said than done. This is the difference between public health tools and personal advice on the front line. Very, very challenging. But just being aware of some of the myths that we've discussed and some of the well-known barriers, most of which involve time management. One's beliefs, so the cultural context. Canada is very different. Weight is seen as very positive, and excess weight and robustness are positive in many, many cultures. So without making assumptions, you can encourage certain behaviors. You may have to work around the cultural differences surrounding The attire, for example, I've gotten questions from various groups about wearing different garb, for example, and being physically active and things like that. So just be aware that there's going to be some different challenges that arise and dealing with them on a one-on-one basis and working with the client. And this ties in nicely to the fifth principle, is defining the goal. Goals are different. Some may have very specific goals, some may be more vague, but understanding that each individual brings a different deck of cards to the table, and that if we can improve quality of life and self-esteem and restore energy, that these alone are very, very big wins during pregnancy. So let me first say, I'll go over just two of the A's because I find that they're very helpful. Number one was asking for permission to discuss weight. And I've gotten questions about, well, how do you do that? It's very challenging. Weight is a very sensitive topic. Well, in medicine and in nursing and allied care, we ask about a lot of sensitive issues, whether it's for sexual preference or infectious disease or harm, suicide risk. You just have to ask the question. But we ask the question in pregnancy a little bit more sincerely by describing the A and W of weight management. For example, if the patient comes in, you can start, I'll just create a really silly narrative here to paint the picture. Oh, hi, how are you? Good, good. And you can say, and they'll be like, oh, and how's your mood been lately? And they'll be like, oh, I'm great. And are you sleeping well? Yeah, I'm sleeping well. That's good. And how's your appetite been? Oh, it's been a little bit up, but otherwise I feel good. Oh, okay. And your weight's been stable? And like, oh, yeah, no, I've gained a couple pounds. And by just asking about appetite first is a really good way to circumvent a very sensitive topic about weight, because it puts us in line with a bunch of other questions that are inherently asked in the clinical encounter and creates a non-judgmental environment around what you really want to get at. So I know not everyone in the audience will ask about weight, but it's very interesting that you can use appetite as a way to get to weight, and that's what we call the A and W of weight management. And so back to the assessment and more proof of concept to the patient or the client that it's not about their personal choice if they're gaining too much or too little. And I put this here just simply to show you that there's mental, mechanical, metabolic, and environmental or milieu factors at play that contribute to excess weight gain. And whether they're mental factors such as an addiction or anxiety or depression, which forcing them to be an emotional eater, or a depression which is leading to sleep deprivation more likely to consume highly palatable options, mechanical factors such as pain or sleep disturbance, but back to sleep again, metabolic factors such as an underlying endocrine disorder, some of the nausea and vomiting associated with early pregnancy, preeclampsia, diabetes, and then the milieu, which is a big, big topic, the family structure, the relationships, whether they're employed, cultural diversity, support at home. There's so many factors at play which may contribute to excess weight gain, and you can target these with exercise and diet, but if you don't address the root cause, you're not going to change, and you're just going to instill, you're going to discourage the patient or the client. So this is why it's important to make your clients aware of the many factors at play so they can come to their care provider with a checklist or their own personal list written down as to things that they may think might be involved with gaining too much weight, just to put it on the radar. In fact, with the 5 A's of healthy pregnancy weight gain, there is a patient handout, and that's available on the Canadian Obesity Network website. And if the individual allied care provider or the prenatal counselor doesn't feel comfortable getting into the nitty-gritty of the weight gain, the patient can bring this picture or this one-page handout with them to their care provider, and that may be the first step to starting a healthy conversation about weight. The patient will then hand it, the provider will then ask them about their weight. And there we have a way to get the conversation going. So as mentioned, there's many different factors to advise on, but we first must address some of the medical comorbidities or complications that may preclude someone from being adherent to our recommendations, which you show here. So sleep time and stress largely play into physical activity. If you're tired, you're not going to be active. You're not going to choose a healthy food option, and you'll be more irritable, for example. So really starting around some of the fundamental behaviors of keeping sleep in the center of the equation. So as I wrap up, I just want to remind you that weight is not a behavior. It's an outcome. It's a clinical outcome that I'm speaking on today to a group of educated care providers, and that the focal point of the discussion in prenatal class should be on the behaviors or factors or barriers precluding engagement in those behaviors. That using the A&W of weight management, whether you're pregnant or not, is a great non-judgmentally curious way to get about weight in a line of clinical questioning that would be asked anyway. But looking again at the 4 M's of weight gain and articulating to your clients that there's epigenetics and there's other factors at play that are contributing. It's not their fault, but there's many opportunities to change and creating a positive environment around that. Again, using SMART goals to measure. So we know what works. We need to work together to foster a healthy environment in the prenatal class and in the clinic to make it work. I've included 2 links for the 2 papers that I've discussed for your reference if you're so interested, and that in the absence of comorbidities, we must encourage the women to enjoy their healthy bodies, to get out and enjoy pregnancy and not obsess or stress. Do we use behavior monitoring, whether the Fitbit or the MyFitnessPal, as the glue that keeps behavior change together, not to identify good and bad days, but to identify gaps for intervention so we can make more days better. And with that, I'd like to thank, again, CIHR, Dr. Keeley at the Ottawa Hospital for her endocrine support, Dr. Adamo for her research support, Dr. Arya Sharma for his support with the 5 A's and his mentorship, and of course, Dr. Andre Gruslin, who passed away but was a tremendous mentor. And of course, Best Starch for the opportunity, and you all for listening. Thank you very much.
Thank you so much, Zach. And now I'd like to open things up for discussion. I noticed you guys were just completely enraptured through the entire webinar and didn't have a chance to even think of what questions you might want to ask. But this is an opportunity. We have about 15 minutes left in this webinar. So if you have a question for Zach, please enter it into the chat box at the bottom. We find that by using live chat, it just ends up becoming extremely noisy with the number of people that we have on the line. So it's much easier if we just use the chat box. And I'm trying to think of some questions myself to ask you to fill the gap, but having listened to it twice now, I'm still finding that all the information that you've given us is just so voluminous, and there's so much that it almost takes a little bit of time to digest some of that information. So I noticed that someone was trying to write a little message, and now I'm not seeing it anymore. But we'll go ahead and give it a few more minutes to see if anyone has anything.
Yeah, and if you have questions, please feel free to email, and if I don't know the answer immediately, I will find someone who does and get back to you.
Absolutely. Can you think back to one of the questions that we had last week, Zach, that might be of interest to this group? I know you mentioned one.
There was a question about smoking in pregnancy.
Yeah.
The question was, where do you essentially stack your what do you do with respect to smoking in pregnancy? Because there is known risk of smoking in pregnancy. And so there has been some work done by Sarah McDonald's group at McMaster, who discusses the effects of smoking cessation during pregnancy. And will the slides be available? Yes, the slides will be available.
Yeah, the slides are actually available right now in the Files section. So if you look on the right-hand side above the chat, there is a Files section. And if you look at the first file, How to Talk About Healthy Eating, that is the file of the presentation. The slides are small because there was a lot of information on there, and it just made it easy to download that way. And the Healthy Eating and Weight Gain Key Messages are just below that.
Question, any suggestions for pregnant women from other cultures or refugees who come with trauma and a lot of stress? That's a great question, and obviously a very, very real and sensitive issue. My suggestions would be to first, go through that whole trauma workup. At this point, if they're tremendously stressed and there's other competing factors at play, maybe they have a PTSD of some kind, and there's other issues, those need to be addressed first. Those need to be addressed with their healthcare provider. and then pointed to resources in the community that can help them. There's no point, again, it's like attacking the 4 M's, right? That milieu of that group of individuals who have PTSD or under tremendous stress, that milieu is off. And so without first targeting that, maybe the depression or some anxiety and using medication or cognitive behavioral therapy, something of that nature, there'll be no true benefit of getting into a very nuanced discussion. You can always, of course, encourage physical activity, but you're recognizing that there's tremendous barriers there. And I'm sorry it's a very superficial answer, but with something so specific and nuanced to the individual and their own concerns and not knowing what other comorbidities they bring to the table, it's hard to give a definitive answer. The other question was, curious about existing resources to support primary care providers in the discussion of healthy eating. How best to support this dialogue? So existing resources, so I always point to the Dietitians of Canada. I know that there is some controversy with respect to the food guide, and I'm going to reserve my personal comments and biases on that. I think it's just important to understand some of the myths. So resources, I don't have any at my fingertips with respect to healthy eating, because right now the food guide is not ideal for creating healthy pregnancy weight gain. And I think I'm just going to leave my comments like that before I get in trouble.
There was a question from Rhonda there below that. Can you speak more specifically about the behavior change strategies used by Habi et al. Published in Midwifery that showed reductions in gestational weight gain?
I'll have to go back to the actual paper there, but there's been some interesting, so some studies, as Rhonda and her group are well aware, some studies have shown no effects, some studies have shown positive effects. It really, in my opinion, comes down to the contact that the care providers have with the patients, and the adherence of the subjects or the patients to the actual intervention. Generally, the more contact, the more aware that the providers are of the specific gaps that the individuals may have with respect to barriers, the better the outcomes. But this is not always true. There's over 20 lifestyle interventions in pregnancy now, and each one has shown slightly different outcomes, largely because the interventions are all very heterogeneous. So the behavior change strategies, I'm waiting to see for specifically how the 5As pans out. There's several groups across Canada working on this, largely in Alberta, but there is the group in Ottawa that's looking at gestational, or how the 5As, how prenatal care providers are aware of the 5As and whether or not awareness can improve dialogue and whether that translates into improved outcomes. Most likely we won't know this information for many years because the studies, to my knowledge, are largely underpowered to detect these changes. But frequent encounters are generally more beneficial. If she has anything more specific to add, she can please type the question. Are you aware of any social marketing campaigns on gestational weight gain? No, I'm not. I'm not aware of any. This is unfortunate because I think that we need to create a healthy environment around pregnancy weight gain, and there's so much in social media right now about it, as I showed you, that this is needed, that it's accepted, it's normal, and that it's not something to be fearing. Can you comment on specific elements that you would feel be important to include in the healthy eating research for pregnant women based on your experience? Caloric literacy, I think, is tremendously important. That understanding the currency which fuels our body, but without creating anxiety or fear around counting calories. Just by simply understanding how the body uses energy, how the body stores energy. If we could articulate that, it's usually an aha moment in many of the lectures I give and many of the classes I give when I compare physical activity, energy expenditure with how much activity you have to do to burn set amount of calories. And I know it's not about burning, but everyone who, goes to has a New Year's resolution, what's their New Year's resolution? Oh, I'm going to lose weight. And what are they going to do to lose that weight? They're going to go to the gym. That's fallacious thinking. It's fundamentally flawed. So I think it's very important to understand how the human body uses calories, how it stores calories, and how we consume calories much more easily than we burn them, and that's an evolutionary conserved mechanism. So if we can work that in somehow to teach the public, because we've been brainwashed by the fitness industry for the past 30, 40 years as to think that exercise really is about calorie expenditure. But over and over again, research shows that it's not. So I would really include caloric literacy. Caloric awareness is tremendously important as well. With the new menu labeling that we have in Ontario, whether or not that translates into altered weights is yet to be seen. But I think having the awareness of what's going in is important, because there's a lot of aha moments when you didn't realize that this meal or that meal was that many calories. And it gives you a chance to think, is it worth it? So as the David Katz, Yoni Friedhoff analogy goes, we need to create sandbags to build a levee, and that each individual sandbag will contribute. Unfortunately, research tests individual sandbags and is quick to negate one sandbag at a time. But to prevent a flood, we need to stack every sandbag we can against this environment, which is really encouraging us to gain weight. Next question. Can you speak more specifically about the behavior change? That was that one. Are you aware? No, that's that one. Can you comment on specific elements that you would feel be important? That's the BC one. We already did that. Any suggestions on how to approach the conversation on weight gain if a client comes to you having already gained beyond the weight? He's concerned about how. Yeah, of course. So there's still a message of hope, right? And so, yeah, they've gained the excess weight, and we're not going to encourage weight loss, but you can still encourage the healthy behaviors, right? Unless they come to you very aware of the literature which is unlikely based on the literature. You need to create a healthy encounter around the pregnancy. So you have to acknowledge that, yeah, it's okay. You don't have to tell them it's the best. The same way you would counsel a patient with diabetes or somebody who comes in slightly hypertensive. These things happen, right? But all is not lost, and that there are things that we can do to change the outcome, or at least stack the deck as best we can in your favor. So all we're asking that they do is try. And I think really it's about engaging in compassionate dialogue. And that's where I think you can make or break interventions. If the care provider is well aware of the literature, the effects of weight gain, and some of the resources specific to that individual that are available in their community, much that we would deal with depression in the prenatal period or physical activity, it's just about meeting them with compassion, finding common ground, understanding where things went wrong, why they maybe gained excess weight, diving a little bit more deeper with your questioning as to understanding why they gained the weight early in pregnancy. Was that a specifically a stressful time, or is there something that's continuing on throughout that whole pregnancy? Did the train fall off the tracks in the interpartum period? Why did that happen? Was it a time issue? Was their job exceptionally stressful? Did they have lack of care provider? Was there relationship issues? There's just so many things. So I think just meeting it with empathy is very important. And I think that, speaking softly and acknowledging that things happen, that life gets in the way, and that there's opportunities for benefit, but just continue to do what you can do to be healthy, I think it holds a lot of weight.
Thank you, Zach. I see that below there's a message from Rhonda talking about an SOGC guideline, the Canadian Consensus on Female Nutrition, that it would be applicable across the lifespan and be a useful resource for this webinar. That's fantastic to know. I was not actually aware of that. The problem with the SOGC guidelines at this point in time is that they're not easily accessible unless you're an SOGC member. We used to be able to access them more directly. So if we do want to get access to them, we do need to look at the what currently is available to us. And I have not been aware that the SOGC has made this more easily available for people. They're available through Google. I haven't had that luck, but I will try again. because basically what you just get is you get a very quick short synopsis from what I have found, but I'm certainly going to be able to look through more of that. And I will make that particular guideline available as one of the resources in the resources and links section of the key messages for healthy eating and weight gain. So we're just about near the end of the webinar, and I don't see anyone frantically typing away at this point in time. So perhaps this would be a good moment to say thank you to Dr. Ferraro for this fantastic information. And I just want to remind everyone that not only will this webinar be available on our archives at the Best Start Resource Center website, there also will be an opportunity to provide us with some feedback about this particular webinar through a evaluation that I will be sending out. Our contact information is on the slide for you right now, so my email address and phone numbers are available there, and Dr. Ferraro's information is available on the right-hand side. And remember that the key messages are always available at ontarioprenatal-education.ca. So thank you so much again for your attention and for participating in this webinar, and thank you, Dr. Ferraro, for your fantastic information. And we hope to see you or hear from everyone in some of the other webinars that we hope to be able to host in the new fiscal year. We will keep you abreast of what the funding situation is. At this point, we don't have any further booked, but the hopes is that in the new fiscal year, we may have some more on offer. So have a wonderful rest of the week, and thank you, everyone, for attending.